Thank you again for joining us. This is the third of our July series. We have our last webinar for July coming next Wednesday, and an email will follow with information immediately following this session. We had such a popular response to this webinar series that we are going to start to resume these webinars in September. So please keep attuned of what we will be discussing, and we look forward to reconnecting with you after August. Each presentation will be 10 minutes today with 5 minutes question and answer period thereafter. My name is Tracy McGuire, and today I'll be moderating the session. So today's research spotlight is going to be on type 1 diabetes and artificial intelligence in diabetic retinopathy. And to start off today's session, we have a very special guest, our patient partner, Ms. Debbie Sissmore. Debbie is a patient partner co-lead for our Diabetes Retinopathy Screening Program. She is a member of the Diabetes Action Canada Steering Council and Collective Patient Circle. She has been living with type 1 diabetes for over 50 years, and due to diabetic retinopathy, she has completely lost her sight over 25 years ago. Now over to you, Debbie. I'm going to unmute.
Yeah, so I've been with DAC since the beginning. In fact, before DAC was even DAC. And I've been living with type 1 diabetes for 53 years. And when I was diagnosed at the age of 4, my parents were told at that time, oh, there'll be a cure for type 1 diabetes in 10 years. And if there's no cure, she won't make it past 40. Well, there's been no cure, and I'm well past 40. But certainly, you know, during my lifetime living with type 1 diabetes, there's been a lot of advances that have been made in the treatment and management of type 1. And I've benefited from those and witnessed those. Just for an example, when I was a small child, glucose wasn't checked in the blood then. You checked it in the urine. We've come a long way. When I was 30 years old, I lost my eyesight from diabetic retinopathy. I'm totally blind. At that time, my husband and I had been married for a year. I'd established a teaching career, and we were just starting out on this, new path of our lives. So when I lost my eyesight, I lost a lot more than my sight. I lost my career, my independence, goals and dreams, and life really as I knew it to be. So when times get tough, I turn to physical exercise. So I became a marathon runner. Unfortunately, during that time, those marathoning days, I was really struggling with hypoglycemia unawareness. You don't feel your lows, and it's not fun. So I was very privileged and so fortunate to receive 2 islet cell transplants in 2003 with the Edmonton Protocol. And we are so fortunate in Diabetes Action Canada to have one of the leaders of the Edmonton Protocol, Dr. Peter Sr., who's very involved with our network. I believe those 2 transplants saved my life. And I'm going to fast forward to today, and I'm thriving. I take very little amount of insulin. For instance, this morning I took 6 units of long-acting insulin, and that'll be it for the day. My A1Cs have remained in the 5 range for many, many years now. But I do my part. Sure, I have little islet cells that are producing insulin right now in my body, but I come to the table, I come to the game. I look after myself. Before I end, I just want to emphasize on the necessity of diabetic retinopathy screening. They couldn't prevent my blindness way back 28 years ago when I lost my sight. I had a year of laser treatments every week, followed by several surgeries in each eye, but they could not save my eyesight. I had the best care. But today, with early detection and treatment, diabetic retinopathy or blindness caused by diabetic retinopathy can be prevented. So with that, I'll send it back to you, Tracy.
Thank you, Debbie. It is always great to hear from you. And I thank you again for coming and speaking to us today about your experience. It's always an inspiration. Thank you very much. So today, our next speaker is Miss Nika Klaprat. Nika is a research assistant at the University of Manitoba. She has had her master's in science master's in kinesiology and type 1 diabetes with Dr. John McGavick. And she is a project coordinator with our Diabetes Action Canada Indigenous Peoples Health Group. So Nika, I am passing the controls off to you, and you are welcome to start.
Good morning, everyone. Thank you for listening in. Like Tracy said, my name is Nika Klaprat. I'm from Winnipeg, Manitoba, which is Treaty 1 territory, and I'll be presenting today on behalf of the Canadian Diabetes and Exercise Network Type 1 Diabetes team. I'd like to start my presentation this morning just by briefly going through our lab's history with Type 1 Diabetes and Exercise research, just to contextualize the presentation a little bit. So we started this arm of our research program in 2013 or so with the VIGOR trial. And the VIGOR trial was, scientifically speaking, a really well-designed study. We were focused on an important issue of preventing low blood sugar with exercise. It also included a randomized control trial as part of its design. And we were able to collect some data using some of the best measurements that were available to us, including continuous glucose monitoring and directly analyzing breath during exercise. We did run into some problems, however, when we tried to recruit and retain participants for the randomized control trial that followed an observational period of the study. And this was primarily because of two reasons. One was that it was a very intensive protocol. So we were asking people to actually physically come into the lab at least 3 times per week, every week for 16 weeks. And the second reason was that the protocol we were literally asking them to run through wasn't necessarily the most enjoyable for our participants. It was not an easy protocol. So upon reflecting on this study, we decided that there was an opportunity for us to restructure our research agenda and have it better reflect the needs and realities of our participants' lives. Oh, I'm not sure what happened there. I got kicked out of the presentation. Okay. But before we got into doing that, we wanted to assess how often that approach to research was being done in this field. So how often were patients being engaged in the design and implementation of research projects pertaining to exercise? So we did a literature review of all of the exercise randomized controlled trials of training studies that had been published in the past 20 years. And we found actually no evidence of patient engagement, so patients being involved in the design or implementation of those studies at all in the past 2 decades. And we also found that patient-reported outcomes, which are variables that include things like quality of life, or the number of severe low blood sugar episodes during exercise, those types of measurements weren't being reported in these studies with any sort of regularity either. So we decided to take our first step into this field by working with people who are affected by type 1 diabetes in creating a list of priority research questions pertaining to exercise and health. And that's where that brings me to the project I'm discussing today. So this project, we have established 4 main objectives that we're hoping to accomplish over the next year or 2. The first of which is to increase our capacity for patient-oriented research in diabetes and exercise. And we want to do that by establishing our research network and working together through a series of projects that improve our capacity as a group. Second, we want to be able to identify what kinds of exercise programs and what about those programs are preferred by people living with type 1 diabetes. Thirdly, we want to work with people who are affected by type 1 diabetes to see what kind of measurements we should be taking in these studies that are most relevant to their lives in the context of exercise. And lastly, we want to work together to co-develop a series of 3 or 4 clinical trials that are answering some of the most important questions for exercise and type 1 diabetes. And we aim to accomplish these 4 objectives through 3 main project arms. The first of which are regularly hosted virtual team meetings over Zoom. So these started out as about once a month, but then we've increased our frequency to every 2 or 3 weeks as chosen by our patient partners to try and improve the efficiency that we reach our other goals. So during these meetings, we've been able to maintain continuous communication as a network. We've been able to discuss project updates, planning, management discussions. We've also been able to share and co-develop some study tools and documents. And finally, we've also been able to offer some training sessions that outline certain topics such as exercise science and different scientific methods. And we're hoping to be able to continue these meetings through to the end of the project to maintain that constant communication and develop our relationships further. Oh. Our second arm of the project is where we're hoping to be able to determine the aspects of exercise interventions that are important to people living with type 1 diabetes. And we're going to do this through what's called a discrete choice experiment, which is basically just an online survey where we're going to ask people living with type 1 diabetes a series of questions that compare 2 different options for exercise training programs. And in each question, they're going to select which option of the 2 they would prefer. So the question along the bottom of the screen, I've taken it out of the exercise context for a simple example. It's summertime here and I'm a frozen yogurt fiend, so I used a frozen yogurt example. This would be one example of a question of 10 or 15 or so in that survey. So both of those options in that question are described by 3 different characteristics. So they're options: flavor, toppings, and syrup. And based on the way that the individuals answering the survey would provide their answers to each question, so which option they select, once we gather enough surveys, we'd actually be able to statistically analyze which variation of flavor, toppings, and syrup we would be able that are preferred, by people living with type 1 diabetes. But of course, these variations won't be frozen yogurt related, they'll be more exercise related. So questions like, what type of exercise? Would you prefer cardiovascular training, strength training, sports-based training, or even the frequency of sessions, once a week, twice a week, 3 times a week, those sorts of things. And we hope to use this information in our final and third arm of the project, where we're hosting a final workshop, or what we're calling a hackathon, in the spring of 2021. So at this workshop, which will more than likely be virtual, just given our current public health situation at the moment, we're wanting to bring all of our scientists and patient partners together to work through a series of not only breakout group sessions, but also full team meetings. So breakout groups will be based on individuals' interest in developing a research protocol that addresses one of the top 3 or 4 research questions. And in those breakout group sessions, group members will not only work together to define a more specific research question, such as following the PICO framework that's on the screen there, but also work together to co-develop a research design for a protocol that can be submitted for funding applications down the road. And then in between breakout group sessions, the full network will come together and groups will be able to present their in-progress research protocols to each other and get feedback on suggestions for other things to consider or improvements that can be made to their protocols. So again, by the end of this hackathon, we're hoping to have 3 or 4 exercise clinical trials designed and ready for funding applications. And ideally, we're hoping that all three of these arms will work together to accomplish the goals that were outlined in a previous screen. We're lucky enough to be able to work with a network of 16 patient partners, including both patients and caregivers, and 15 scientists, 3 of whom actually live with type 1 diabetes themselves. And we're hoping to be able to work together as a network throughout the entire research process. So some of our patient partners have actually been working with us for about 1.5 years now and helped us actually understand what kind of methods we should follow in this project as well. But we're now in the early stages of the study design phase. So we've expanded our team and we're hoping to be able to work together as we co-develop studies, conduct studies, analyze findings, and disseminate those findings over the next year or two. As I mentioned, we are in the early phase of this stage, but we have accomplished some of our target endpoints, one of which is submitting a methods paper describing this project, and that was co-authored by some of our patient partners who helped us design the project. Our patient partners have also helped conceptualize 2 additional studies that are even separate from this project, one being a qualitative study and one being a project for building a collection of exercise resources to support people living with type 1 diabetes. We've also been able to co-design our discrete choice experiment survey over the past 6 or so months. And we're planning on starting data collection on that later this summer and in the early fall. And we've also been able to host 4 virtual team meetings since April so far, but our 5th is actually scheduled for tomorrow afternoon. I'll breeze through this because I've already kind of touched on these outcomes. So more short term, by summer or fall of this year, we're hoping to run that discrete choice experiment and determine the list of variables that should be measured in every exercise study. By spring 2021, we're hoping to have hosted a number of training sessions that are both patient partner led and scientist led. And that would just prepare us for our hackathon where we're designing those studies. But ultimately, we're hoping to continue our involvement as a research network and continually co-develop and co-run these studies. And hopefully by doing that, we're going to improve the quality, accessibility, and relevance of exercise resources for people living with type 1. And just quickly, some lessons that we've learned. Again, we're really early on in this process, so we do anticipate learning more as our process continues. But as of right now, we've learned, 1, that you need to quickly assess what type of approach is going to work for engaging individuals in your project, group, or network. And that should be continually reassessed as people's lives change. So for example, COVID-19 has changed all of our lives quite a bit, so we've had to reassess continually what's going to work for our team. And finally, another lesson from COVID-19, that you have to plan far in advance for any possible complications that can come up. So for us, there were complications, particularly with scheduling, translating documents bilingually. But the biggest one was trying to figure out the accessibility of using technology to begin with to host a lot of what's going on in your project. So we're still figuring out some of these issues, but these are just some lessons that we've taken away so far. And with that, I'd like to acknowledge some of our sponsors and supporters, which include Diabetes Action Canada, the DREAM Research Team, and the Center for Healthcare Innovation in Winnipeg. I'd also like to thank our patient partners who have been a part of this project, both past and present, but our current members are on this screen with their permission. And I'd like to thank Drs. Shivani Goyal and Dr. Julia Witt, who have both helped us with our discrete choice experiment and other aspects of our initiative. And with that, I'd just like to wrap up and say thank you.
Thank you very much, Nika. Very interesting work. We have a couple of questions in our question and answer. The first is, how do you evaluate patient engagement in the project, and what instruments or scales do you use?
We're still working out the evaluation aspect of things, because again, we're still very, very early on. We have been taking, it's mostly like a qualitative assessment at this point. So mostly just taking notes on how our plans have changed with different engagement strategies, as well as like what changes we've made to our documents that were proposed by our patient partners. But we are also trying to just work together as a network. So they're mostly part of our team, and it's not necessarily an evaluation of our patient engagement as a whole, if that makes sense.
Mm-hmm. Great, thank you. I have one other question. Can your project be applied to those who live with type 2 diabetes?
I'm sure our approach definitely could be. I wouldn't say that the co-designed studies that are going to come out of it would be, obviously, but I would say that the approach is something that can be followed in multiple different areas, whether it be even diabetes or not, which is why we co-wrote that we co-wrote that paper outlining our methods for this project so that anyone can follow it and that we can also follow it again in the future with other populations as well.
Mm-hmm. All right, thank you, Nika. Very interesting work. Moving on to our next presenter, we have Jamie Boisvenu. Jamie received his master's in epidemiology with Rose Young and Jeff Johnson at the University of Alberta. He is currently a PhD student at the University of Alberta in Public Health Epidemiology under Dr. Peter Senior, and he is a Diabetes Action Canada Knowledge Translation Awardee. Welcome, Jamie, and thank you for presenting today.
Thanks, Tracy. You can all hear me, correct? Yes?
Yes.
Excellent. Good morning, everyone from Edmonton. It's raining and terrible here, but I can hopefully bring some sunshine to my presentation this morning. As Tracy said, I'm Jamie Boisvenu. I am presenting my PhD thesis research as part of the Diabetes Action Canada doctoral scholarship, assessing narrative inquiry into understanding the type 1 lived experience and its motivations in seeking diabetes health services and education in Alberta specifically. So as many of you already know, type 1 diabetes requires therapeutic intervention, typically focused around glycemic control or blood sugar control. And we know that that constant management is essential for preventing short and long-term poor health outcomes. Delivery of insulin specifically has traditionally been done through multiple daily injections, but thanks to advances in technology, we now have access to insulin pump therapy. And this is a good thing for people living with type 1 diabetes. It is a 24-hour-a-day, 7 days a week job, and sometimes constant management can lead to diabetes burnout. However, the interesting thing is that only about 10% of Canadians with type 1 diabetes are on an insulin pump in Canada. And so, how do I skip? There we go. The Alberta Pump Program was piloted in 2013 to sort of introduce the insulin pump for people living with type 1 diabetes. And this sort of was born out of a necessity for evidence that was needed to make critical funding and policy decisions. The pilot itself did not necessarily meet the standards for cost effectiveness, but it was found that it was comparably safe to multiple daily injections and was really good at improving quality of life. Today, the pump is available to all Albertans with type 1 diabetes who meet the eligible clinical criteria for coverage. And there are some ups and downs to insulin pumps versus MDI. Some advantages: fewer needle pricks, automated dosing calculations, a greater flexibility to accommodate the spontaneity of daily life, as well as, and what researchers are very much so interested in, is the increased precision of insulin delivery. There are some disadvantages, as I mentioned. It can be very expensive. There is quite a learning curve, a lot of technical malfunctions, possibility for human errors, and introduction of contamination during set changes and things like that. Looking at the lived experience of pump and MDI users, which has not really been adequately captured in Alberta thus far. So this leads us to our objectives, which is, number one, understanding how the lived experiences amongst persons with type 1 diabetes have influenced diabetes management specifically. Understanding the motivations and barriers in pursuing diabetes-specific education for pump and injection users, as well as our third objective is to employ KT strategies using the findings from 1 and 2 to inform health services within diabetes care. Next slide. So that leads us to our research question: how have type 1 diabetes lived experiences influenced the ability of those on pump or injection to self-manage diabetes and navigate healthcare services effectively? So I wanted to provide a little bit of a picture of progress thus far. As I'm seeing with some of my colleagues presenting already today, COVID-19 has thrown a bit of a curveball in many projects. What we originally had intended to accomplish did not necessarily take place thus far. And so at this point, we were expecting to be generating data and interviewing patients with type 1 diabetes. But our project took a little bit of a twisty turn. So our stakeholder engagement, just to begin with, required protocol revision and a feasibility assessment of our project in order to keep stakeholders engaged, which was a good thing. Then COVID-19 came along, which required us to completely rewrite our ethics protocol and develop a new patient recruitment strategy, as well as re-engage those same stakeholders and inform them of, you know, the changes to the project, etc. It also led to us requiring additional collaborators and patient partners. So that's kind of where we're at right now, in that experience co-design phase in which we have patient partners and clinician partners engaged in the project to help us sort of navigate this space. Following that, we will be seeking ethics approval written together with patient partners and clinicians to get that approval and then start generating data. Next slide. So our study design consisted of a qualitative study. We're looking at doing narrative inquiry through semi-structured interviews using that experience co-design based strategies with patient partners and, I should say, clinician partners as well. We want to obtain a purposeful sample of about 30 to 40 participants in 2 groups: continuous subcutaneous insulin infusion and those on multiple daily injection. And our inclusion includes, of course, anyone with a type 1 diagnosis, at least 18 years of age, on pump or injection, and then able to communicate fluently in English, verbal and written, and just having an overall interest in sharing their diabetes life story. Next slide. And of course, we have some very important sex and gender considerations within our research. We know that there is clinical interest in understanding the healthcare seeking behaviors amongst people with type 1 diabetes. And within our specific clinic in Edmonton, the K Edmonton Clinic, we know that more women follow up than men. And this is historically shown through the evidence as well in healthcare utilization rates. Influences in seeking healthcare services and education also differ among sex, and it is something that we want to consider within the narrative interviews. And of course, you know, we will also want to try to gain an understanding of patient-provider relationships. For example, female patients to female physicians. And then, of course, we understand that, you know, in previous literature with diabetes, we have seen gender-mediated differences in how diabetes management is carried out and how that influences health outcomes. However, more evidence is needed in this area, so it is a consideration within our research. So in terms of data generating strategies, participants will be asked to complete a pre-questionnaire that's developed through REDCap. This will answer basic demographic questions and diabetes management questions that will hopefully have the purpose of reducing the burden of the narrative interview so that we can get into some of those deeper phenomena of interest. Of course, we're using the blended narrative semi-structured interview approach, as I mentioned. This will now be conducted via audio and video recording using video conference software. We will be transcribing all interviews, and then, of course, the interviewer is going to conduct a reflective interpretation or so-called research journaling to bracket oneself after each encounter, and this will sort of help in the analysis and the interpretations of the findings, which will be co-constructed with the participant and the researcher themselves. So within our analysis, we will be conducting an impartial rereading of each narrative. And the purpose of this is to work together through it with the patient, with the participant, in order to preserve their voice, to say, you know, is what you said, is what is written here, what you said within the interview? Do you feel comfortable in us interpreting this? And then after we've thematically transcribed and coded each interview, we will go back to participants and say, okay, are our interpretations an accurate reflection of what was discussed in this interview? And then, of course, we're moving into a sort of we want to do a part of a mixed methods quantitative arm of the overall qualitative project by introducing a new technique that actually has never been done before in the diabetes space, and that is referred to as epistemic network analysis. Next slide. So what is ENA? So very shortly, very briefly, it models cognitive networks for assessing patterns in complex thinking. It was developed by David William Schaefer out of University of Wisconsin and used in learning analytics. So it's specifically designed to understand how a person arrives at learning a certain concept. And as you can imagine, this is critically important for diabetes lived, learned life experiences. And it'll help us identify some connections among those speech utterances and interview data. And then it can, of course, be visualized, which on the next slide shows us that those cognitive connections can be sort of illustrated further. So in the far right graph, you see individual A who is working through an engineering problem with their classmate in the middle, who is individual B. And the thicker, more dense lines between the four quadrants of the graph demonstrate the cognitive connections that have been developed through interview data, through speech utterances, that has highlighted the region in which this person is able to arrive at those learning problems and those decisions. And in contrast to the middle graph it's different. So person B has developed a different way of arriving at the problem using knowledge design and attributes in that second quadrant. The far left graph shows basically just an overlay and how you can average out the weights of the different connections between the users. So within the diabetes space, this is ideal for looking at the lived life experiences that lead to diabetes-specific choices. And it also helps us to identify connections that are made between core knowledge and diabetes management, specifically between pump and MDI users. So then we're going to, of course, involve knowledge translation and dissemination. One of the most important components of our project. We're going to explore a knowledge synthesis together with patient partners and clinician partners to look at the existing literature and how it compares to our findings. And of course, we will be co-creating knowledge together through a series of iterative working groups that will focus on how we can disseminate that information back to the community. And so on the next slide, I have the various knowledge users and knowledge brokers. So our knowledge users involve type 1 patients and families, researchers, nurses, dietitians, physicians, care managers, and anyone else within that diabetes space, as well as we want to reach out to knowledge brokers, and some of which we have already engaged, the Edmonton Zone Diabetes Quality Council, the Diabetes, Obesity, and Nutritional Strategic Clinical Network with Sonia Battaglia, the Clinic and Data Advisory Management Committee for Enhanced Diabetes Surveillance and Research Infrastructure. That is our main data repository here in Edmonton. And then, of course, the multicultural health brokers will help us in navigating the cultural spaces around diabetes as well. And we plan to do this through the Paris framework, the Promoting Action on Research Implementation in Health Sciences. So using that sense-making approach to knowledge synthesis and sort of collating the evidence and comparing it to our own findings, we're going to situate that within the context of the diabetes clinical space and the community itself. So we're going to look at diabetes leaders to develop, to help identify those champions, and then that will help us sort of facilitate and disseminate that information and our findings back to those who really matter, which on my next slide, thank you, Tracy. We have two domains that we've sort of compartmentalized. Scientific communities, we're going to share our research with the DON-SCN, the Diabetes Action Canada, Alberta Diabetes Institute and Foundation, Diabetes Canada specifically, and then Edmonton Zone AHS, the Think Tank Network, and then also KT Alberta. And within the public space, we're going to look at engaging news media and social media. Suling Go with Global Health Matters is a good example. DON-SCN quarterly newsletter, KT Alberta, which we've had numerous qualitative research articles that have been published by KT Alberta. We'll go back to local diabetes groups. And then, of course, the Edmonton Diabetes Chapter and the U of A Festival of Health, which happens annually, which probably is not going to happen this year, which makes me kind of sad. It's a good forum for the public to come to the university and learn how to get involved in research and learn about research. So there's lots of different avenues in which we can share this information, and always open to additional ideas from everybody watching. Next slide. So with that, I'd like to just take a moment and acknowledge the wealth of knowledge and wonderful people who are involved in this project. Some who are not listed, but I acknowledge you all the same. My PhD committee meeting, Dr. Rose Young, Dr. Paul Vogelers, Dr. Peter Senior, and Dr. Alex Clark. The people within Alberta Health Services, AHS Analytics, the Diabetes Infrastructure for Surveillance, and the DON-SCN, and of course, School of Public Health, Department of Medicine, Division of Endocrinology, and Diabetes Action Canada for funding this research. So thank you for your time today, and I open it up to any questions.
Thank you very much, Jamie. Very interesting work. Although you can't see it, our Twitter is very much active about this particular project. So thank you very much for that. I do have a question, actually, as I've been listening along. And I noticed that a lot of the KT and dissemination that you have planned is in Alberta and on the West Coast. Is there any plans to work out on the East Coast and expand the research and scale it to that part?
I mean, probably. We just have to make friends. I think that it's absolutely critical to spread and scale. And the original idea and proposal for this project was to look at doing a national strategy, which was not funded by CHR and recommended to sort of scale back and look at Alberta and the local context first. So that is kind of why our KT strategies are situated within the Alberta space right now. But hopefully, if our findings and interpretations and impact of our research is positively received within the Alberta diabetes community, I think it's definitely worthwhile to collaborate with other provinces and other researchers across Canada for sure.
Great, thank you. And that's where Diabetes Action Canada comes in. So
absolutely.
Welcome to the network. We're really hoping to help facilitate that. Well, thank you very much, Jamie. I don't see any other comments, but definitely check out the Twitter feed because a lot is being asked on that. So by all means, please respond there. So our next presenter is Gabriel Lapetit-Aymon. Gabriel is a he's a graduate student with the Polytechnique Montreal. He is studying artificial intelligence and deep learning, in particular with medical and fundus images. So I'm passing over the controls to Gabriel as we move forward. Excuse me. And on to you.
Yeah. So I'm going to present you a research project conducted by two research laboratories, including mine, and 4 Canadian retinal specialists. It's moving. Okay. And the objective of this research project is to use artificial intelligence to screen diabetic retinopathy in Canada. So for those of you who are not familiar with diabetic retinopathy, it's a complication of diabetes which causes damage to small blood vessels and neurons in the retina and may lead to visual loss. And over the 3 million of Canadians living with diabetes, approximately a quarter suffer from diabetic retinopathy, which put this pathology as the first leading cause of blindness in working age adults in Canada. So it's a major pathology for ophthalmologists. But as Debbie Sissmore explained it earlier, most of the vision loss could be prevented by early treatment, and so by early screening of this pathology. So the screening of this pathology is really an important matter. And today, how that is done is, the screening is performed by teleophthalmology networks. So in practice, diabetes patients go to specialized center where their image of the retina is taken and then sent it to trained readers that choose whether or not to refer the patient to a retina specialist. Now, the problem is, on one side, the number of diabetic cases is continually increasing, and on the other side, on the clinical side, the capacity of those telemedicine networks is limited by the number of trained readers they have. And this leads to a situation where 40% of Canadians with diabetes today are not screened for diabetic retinopathy. And so what we are trying to do with artificial intelligence is to close the gap between diabetic patient and retinal specialist by automatically processing those images with AI instead of trained readers, so to ensure a more fluid communication between them. Now, using AI, using AI to screen specific pathologies is a well-studied problem. In fact, a number of data science challenges have already been organized on the matter of screening diabetic retinopathy from fundus images. And this led to a lot of research and a lot of algorithm. But when we studied those algorithms, those state-of-the-art models, and when we tried to apply them to the Canadian telemedicine context, they didn't perform as well as we thought they would. And through further studies, we realized that there were several challenges, technical challenges that must be overcome to deploy them properly. And so today I'm going to present to you 4 of these challenges and a bit of the solution that we are investigating. Now, I do realize that most of you are not expert in artificial intelligence. So what I will do is briefly show you some technical solution that will one day make possible the automatic screening of diabetic retinopathy in Canada. But more generally, what I would hope to give you is some insight on what are the key questions to ask when we are talking about artificial intelligence as this technology is spreading into society. So it's a bit of those 2 objectives here today. So the first challenges that we faced, I don't know why it's moved twice. Yeah. The first challenges that we faced concern data. Now, to understand this challenge, you need to know that the way learning algorithm works is by trying to mimic behavior that they learn from a training data sets. Now, this means that especially deep learning algorithm actually replicates the bias of these data sets. Now, one example of that is concern facial recognition algorithm, which are known to perform poorly on images of women with darker skin tones, simply because there is less images of the specific population in the training data sets. Now, those kind of poor performance, we really don't want them, and we really want to avoid them in a clinical context. And in order to train, and most importantly, in order to test our algorithm on Canadian population, we need a Canadian funded data set. with the proper annotation. And the problem is none exists today. So it left us no choice but to build our own data set, and that's what we are doing right now with 8 retinal specialists that are annotating or labeling both diabetic retinopathy and macular edema, and also along with 12 anatomical markers, which make this database quite unique, in fact, in the world, because to our knowledge, no database have been annotated with such amount of biomarkers. So it's a really good thing. I will skip the next slide for time reason. The second problem, okay. Yes. The second problem concerns image quality. Image quality of fundus images is not always sufficient to provide a reliable diagnosis. The problem with that is our algorithm can only do what they are trained for. And that means that in our case, they are trained to predict a diagnosis, and that's what they do, even if the quality is insufficient. So we have to prevent them from predicting a diagnosis from an image that they could not do, could not predict. So we developed an algorithm that can actually predict the quality of an images, and if its quality is too low, we reject these images. And to do so, we used a standard method used by clinicians that rely on vessel's clarity around the macula. So we segment a vessel, and then we provide a quality score. And this actually improved the reliability of our screening algorithm, and we had good success with that. The third problem that we've identified is that state-of-the-art algorithms don't capitalize on multiple views. That is, when retina specialists read a fundus images, they actually look at multiple pictures of the same eye and picture of different angle, and they make their diagnosis from that. But the state-of-the-art algorithm just look at one single images. And so they don't exploit all the information that we can provide them, and that's a shame. So we developed, and we are developing a new neural network architecture that can extract information from those many views, and then that can combine them into a final screening prediction that we hope will better match the diagnosis given by retinal specialists. The fourth and last challenges that I'm going to talk about in this presentation concerns interpretable diagnosis. State-of-the-art models only provide one diagnosis, and that's it, basically. They do not give us elements to support or explain their diagnosis. And we believe that for a clinical application, it's a problem. So, for example, when your algorithm disagree with a clinical label, we want to know why. And I mean, when two experts don't agree on a diagnosis, they can discuss to find an agreement, but that is not possible with an algorithm that doesn't give us anything about why he chose this diagnosis and not another. So we are investigating algorithms that identify lesion and abnormalities on the image. It's what you can see on the top image there, instead of directly going to the diagnosis. So it predicts abnormalities, it predicts lesion, and from that, it actually computes a diagnosis. And so we can then measure what are the important lesions and for those. So this approach is a little bit more complex, but we are confident that with the help of the Canadian data set that we are building, it will lead to a more reliable screening. So yeah, to summarize, we are currently exploring technical solutions to overcome challenges that prevent current state-of-the-art screening models to be applied to teleophthalmologic diabetic retinopathy screening. And we do that by first building our own training and testing data sets, by enhancing algorithm reliability, and by investigating interpretable models. But most of all, by trying to change those algorithms to match what retinal specialists are doing. And that maybe is the most important thing that we'll realize during this project, is that the collaboration between artificial intelligence researcher and retinal specialist is the key to provide a reliable automatic teleophthalmology screening for the 3 million people living with diabetes in Canada. So yeah, with that, I would like to acknowledge Diabetes Action Canada, the CIHR, and the Université de Montréal for funding this project, and I would like to thank you for your attention.
Thank you very much, Gabrielle. Very interesting work. I know this is something that we at Diabetes Action Canada are quite interested in, and seeing how it evolves to really feed into our diabetic retinopathy screening program. So I do have a question while I'm waiting to see if anyone else does as well. And we're wondering, what do you see the role of patient partners playing in this particular project?
This is a difficult question for me, obviously, because we don't have as much contact with patients as maybe we should or maybe we would want. Because so it's already a big step to have a lot of contact with clinician for in our perspective and clinical specialists, and we count on them to give us insight about what patient really need. But I think there is a need to because ultimately this is for the patient. I mean, so we need to ensure that we are fulfilling correctly their needs.
I would imagine that a lot of it would have to do with helping build out the right population base in order to read how you were mentioning you're missing certain demographic and sex and gender representations in the publicly available data sets. That would definitely be a great opportunity for patient partners to build on. So thank you very much. I don't see any other questions in the question and answer, but they'll definitely be trickling in. So when they do, we'll be making sure. Oh, actually, we just got one, just as I was saying that. Who is contributing data to Canadian data sets? Are different patient populations going to be represented to train the algorithm, i.e. Indigenous peoples?
Actually, so right now we are working with a data set provided by a hospital from Montreal, and that includes Indigenous population. Ultimately, it would be great to have a data set from other hospitals in Canada, but we are using telemedicine data, and those actually use a lot of various population.
Great. Well, thank you very much, Gabrielle. Very interesting work, as I mentioned. We're again looking forward to hearing more as this project evolves. So in closing today's webinar, I want to thank all our presenters, Debbie, Jamie, Gabrielle, Nika. I really thank you for joining us today. We all found it very interesting. Our next week's spotlight, our research spotlight, will be on patient engagement and knowledge translation. And this session will be conducted in French with simultaneous English translation. So a little different than what we've done before. The details for this will be provided in the registration as well as emailed to the day before. So thank you again for spending your Wednesday morning with me and with all of us here at Diabetes Action Canada. And we look forward to seeing you next week.